Please mute all lines. Good morning, everyone, and welcome to the first education session for the Coding Corner, Medical Coding Education for January 2025. Today, we'll be covering 2025 ICD-10-CM Guidelines General Coding. My name is Kristen Robinson. I am a CPC, CPMA, CCC, and CRC with the AAPC, and I'm the creator and educator for the Coding Corner. If you would like to find the Facebook group, it is the Coding Corner. We also have a YouTube channel where this will be uploaded post the live call for anyone to review on demand. So let's start with our disclaimer. Just remember that the information given within this presentation is known to be current and accurate as of the date of the presentation. Today is January 4th, 2025. The ICD-10-CM is copyrighted by the World Health Organization, or WHO, which publishes this classification. The information in this resource is only a snapshot of some aspects of how to achieve the most accurate ICD-10-CM code and how to document accordingly, and should not be considered authoritative. All readers are encouraged to carefully review the ICD-10-CM coding rules and guidelines, codes, and content. I have also included in the resources at the end of this presentation a link directly taking you to the ICD-10 guidelines. Today's agenda will include the conventions, ICD-10-CM book division, format and structure, instructional notes, and code types. Our guideline conventions. The conventions for the ICD-10-CM are the general rules for use of the classification independent of the guidelines. These conventions are incorporated within the alphabetic index and tabular list of the ICD-10-CM as instructional notes. ICD-10-CM book division. So we'll be talking about the alphabetic index. And as we all know, if you are a current coder, you know that we always want to look up our terms in the alphabetic index for the corresponding code before we move to the tabular list. You never want to start in the tabular list because you could be ultimately picking the incorrect code. We want to make sure we are dialing down within the alphabetic index before we move to the tabular list. Okay, so a little brief information. If you are new to coding, the alphabetic index consists of the following parts. We have the index for diseases and injury, the index of external causes of injury, the table of neoplasms, and the table of drugs and chemicals. And if you are using your ICD-10 book to follow, you can see section IC2 of the neoplasms, the section IC19 for adverse effects, poisoning, and underdosing, and toxic effects. As far as the tabular list goes, this is where you are going to find your actual diagnosis codes that you are looking up, and they are divided by chapters based on the body system or condition of the body. Format and structure. Okay, so now we're going to get into what the tabular list contains. We have categories, which are our 3-character primary codes. Typically, that is going to be alphanumeric, so you are going to have a letter followed by 2 numbers. You have subcategories, which are 4 or 5 characters. So you have your category, which is your 3 primary characters that are alphanumeric. Then you will have your 4th and 5th digit that follows the point or period in the diagnosis. Then you have your complete code. This can be the 3 original category. It can be the 4th or 5th digit including, or 6 or 7 characters ultimately. Now, it depends on the chapter. It depends on the code to whether it is 3, 4, 5, 6, or 7 characters. Characters include either a letter or a number. Codes are applicable for seventh character, and they are still referred to as a code, not subcategories. And there are specific codes that have the applicable seventh character and are considered invalid if you are missing the seventh character. Those are typically going to be a letter. And for certain sections of the book, that will be A, D, or S. So for primary treatment, you would use the A. We'll get into that further. For D, that's subsequent treatment. And the S would be for sequela, which would be follow-up to a previous condition with residual effects. Okay, so let's talk a little bit more about the placeholder character. So we have the X. The X is what we call a placeholder. So there are certain codes that don't have digits for that particular spot in the code. So they use a X as a placeholder for certain parts of the code. So you will see in your code book, if you are following along, for example, there is a for a unspecified fall, you're going to have a W19 followed by a period, X, X, and then A if it was a initial effect or initial treatment. As you can see, the example on the screen, it shows that your T36 through your T50 codes, the X must be used for the code to be considered valid. If you miss that X placeholder, your code will be considered invalid and not a appropriate code. So as you can see, for example, the T36.0X5A, the X must be in the fifth position in order to be a complete code. This code is for the adverse effect of penicillin's initial encounter. So let's talk a little bit more about abbreviations. So the alphabetic index has abbreviations as well as the tabular list. So a couple that I want to specifically call out that we use in everyday coding is NEC, which is not elsewhere classifiable. This is an abbreviation stating that it represents an other specified code. When a specific code is not available for a condition, the alphabetic index directs the coder to the other specified code in the tabular list. Now, we also have NOS, which is not otherwise specified. This is an abbreviation that is equivalent to unspecified. So let's talk about that a little bit deeper, okay? So just remember to correlate when you see NEC, think other specified. When you see NOS, think unspecified. So it means that your provider documented either a diagnosis that was in fact completely specified, but there is not a diagnosis code for that particular condition, and then you would use the other specified. Now, if your provider does not give you a specified diagnosis, they just say chest pain, and they don't say it's other type of chest pain or a specific type of chest pain, you are going to default to NOS or unspecified. So let's talk about punctuation. So we have a couple different things that we're going to cover today. First of all, we're going to start with brackets. Okay, as you see on your screen, the brackets appear in a squared off closure, which is different than parentheses, which is a rounded closure. Brackets are used in the tabular list to enclose synonyms. This is an alternative wording or an explanatory phrase. So brackets are used in the alphabetic index to identify manifestations. So for example, the first thing that comes to mind is if a patient has Alzheimer's dementia and you have to use a F ICD-10 code as well as a G ICD-10 code, you are going to have brackets that are going to enclose the manifestation of the primary code you are using. And as I've stated, if you are following along in your ICD-10 book, you will see that in that specific scenario I just gave, but there are many other scenarios within the book that use the brackets. So next we have our parentheses. As mentioned, these are your rounded enclosures. These are also used in both the alphabetic and the tabular. And this is to enclose supplementary words that may be present or absent in the statement of a disease or procedure without affecting the code number to which it is assigned. So basically, it's just giving you additional information. It's supplementing additional words to help you with the diagnosis you are picking. So, to further clarify, it says the terms within the parentheses are referred to as non-essential modifiers. The non-essential modifiers in the alphabetic index to diseases apply to subterms following a main term, except when a non-essential modifier and a subentry are mutually exclusive. Okay, so that means the subentry takes precedence. For example, in the ICD-10-CM alphabetic index under the main term enteritis, you will have acute as the non-essential modifier and chronic is a sub-entry. So in this case, your non-essential modifier for acute does not apply to the sub-entry chronic. Okay, so if you are new to coding or you are a seasoned coder, we know that our guidelines tell us that if acute and chronic conditions occur as two separate codes and not as a combination code, we know that we will place the acute diagnosis before the chronic diagnosis. Now, there are some diagnosis codes that are acute on chronic. And in those cases, that's a combination code where it encompasses both your acute and your chronic of that particular diagnosis. And lastly, on this slide, we're going to cover colons. These are used in the tabular list after an incomplete term, which needs one or more of the modifiers following the colon to make it an assignable to a given category. Okay, so let's talk a little bit more about coding terms. So the word and. Okay, the first one we're covering is and. So this should be interpreted to mean and or when it appears in a title. So if you are following along in the book, you can see section 1A point 14 or point 14 for the use of the term and. We also have other codes. So codes titled other or other specified that we mentioned previously in the presentation for NEC codes, these are used for when the information in the medical record provides detail for which a specific code does not exist. So, like I stated, in the alphabetic index, entries with the letters NEC in the line designate other codes in the tabular list. These alphabetic index entries represent specific disease entries for which there is no specific code that exists. Therefore, you have to use the other code. Remember, we mentioned earlier that let's say that your provider tells you this is a specific type of condition, but we do not have a specific ICD-10 code to classify the specified diagnosis that the provider documented. And that's when we are going to default to our other code type. Next, we are covering unspecified codes. Codes titled as unspecified are used for when the information in the medical record is insufficient to assign a more specific code. For those categories for which an unspecified code is not provided, the other specified code may represent both other and unspecified. And again, if you're following in your book, you can see section 1B.18 or 18 for the uses of signs, symptoms, and unspecified codes. So, further describing our coding terms, we have includes and inclusion terms. So, our includes notes. This is a note that appears immediately under our three-character code title to further define or give examples of the content of the category. So, basically, what that's telling you is that if you see a drop down of diagnosis codes that are included in the diagnosis character code you're using, the alphanumeric character code, that means that any of those following diagnoses are included in the main character. That means that if it's included, you do not code it separately. Okay, that means that it is encompassed in that three-character code. Also discussing inclusion terms. The list of terms that is included in some codes. These terms are the conditions for which that code is to be used. The term may be synonyms of another code title, or in the case of other specified codes, the terms are a list of the various conditions assigned to that code. The inclusion terms are not necessarily exhaustive, which that means is just it may not be every available option, but it's telling you to see this as an example of examples you can use that are inclusive to this term. Additional terms found only in the alphabetic index may also be assigned to a code. So now let's talk about our excludes one and our excludes two notes. So this is something that seems to trip up coders occasionally on when is it appropriate to use excludes one versus excludes two. So the major take back on excludes one versus excludes two, and I have it bolded here. For excludes one's notes, this is not coded here. That means an excludes one note indicates that the code excluded should never, let me repeat, never be used at the same time as the code above the excludes one note. That means an excludes one is used when two conditions cannot occur together, such as a congenital and an acquired condition. For those of you that may be new to coding, congenital means you were born with it. Acquired means that it was developed after birth. You cannot have the same condition in a congenital format and an acquired format at the same time. You were either born with it or it developed after birth, period. Okay. For an excludes two, that just means not included here. It means that if both conditions occur at the same time, then it is acceptable to use both codes, but only when appropriate. We as coders cannot make that assumption. That means that your provider needs to be documenting appropriately to tell you that both conditions occur together. Okay, code first and use additional. Okay, so also in your book, you can see section 1B.7 for multiple coding for a single condition. So we have these notes in our ICD-10 book that are going to tell us if you are using a diagnosis code and it says code first and then it gives you an additional diagnosis, that means that that additional diagnosis must be sequenced prior to the diagnosis code you are using. Okay, so for instance, if a patient has hypertension and congestive heart failure or hypertension and chronic kidney disease, you need to code first the appropriate combination code for your hypertension with the appropriate CHF or congestive heart failure and the appropriate CKD. So you're going to use your hypertension combination code followed by your appropriate congestive heart failure diagnosis code or your appropriate uh, chronic kidney disease or both when applicable. Your use additional code note means that whatever diagnosis code that you are using, if it is applicable, you can use an additional code after the code that you are currently coding. Okay, so just make sure you know the difference between these two. If it tells you to code first, it means it is required that you code first the additional diagnosis. Use additional typically means if documented or if applicable, you can also code the etiology or the manifestation code in addition to the code you're currently using. So now let's talk about with C and C also. So there's some distinction here. The word with or in should be interpreted to mean associated with or due to when it appears in the code title. Okay, so um, if your provider says hypertension with chronic kidney disease or chronic kidney disease with hypertension. However, they want to state it, it is telling you it's associated with or due to. There are certain causal conditions that you assume are related. There are others where your doctor or provider needs to explicitly tell you whether they're related or not for you to code them as a combination or as related. There are other conditions where you cannot assume they're related, and your doctor has to tell you that they are in fact related or are unrelated to each other. Okay, so just remember you need to make sure that your provider is documenting appropriately so you can pick the highest specificity. For C and C also, the C instruction is followed by a main term in the alphabetic index that indicates another term should be referenced. Meaning, if you're looking in your alphabetic index and it tells you to see another area, then you need to go to that other area to find your final diagnosis choice. Okay, if you see also, that means it could also be listed here. C means go there. C also means you can if it's applicable. So hopefully that clears that up when you are looking in your book. So let's talk about code also and default codes. Okay, code also. That means that the note instructs that two codes may be required to fully describe a condition, but this note does not provide sequencing direction. The sequencing depends on the circumstances of the encounter. So there are certain situations where the patient can have both diagnoses, but the patient's coming in for one and just associated with the other. Okay. So they're coming in for a leg wound and they're being seen specifically for that leg wound, but they also have diabetes. There are specific guidelines in your book that tells you how to sequence those codes. Okay. You may be seeing your orthopedic doctor for a hip replacement, but you also have diabetes. They may give you both of those codes, but you wouldn't use the diabetes as the first listed or primary diagnosis because that's not what they're coming in to see your provider for today. They're coming in to see the provider for a diagnosis related to a hip injury or the need for a hip replacement, whatever the case may be. You need to make sure you are sequencing your codes appropriately based on what the doctor or provider is seeing the patient for on that date of service. So, default codes, these are codes that are listed next to a main term in your ICD-10 alphabetic index, and they are a default term. That means that if your doctor or provider does not give you additional specificity, you will use the default code. Okay, code assignment and clinical criteria. So, the assignment of diagnosis is based on the provider's diagnostic statement that a condition exists. Okay, there are certain diagnosis codes that you don't have to have proof of a lab result or any other test to confirm or corroborate your provider's statement. The provider's statement that the patient has a particular condition is sufficient for that code assignment. So if your provider documents that a patient has HIV, you don't need to look for lab results. The provider's statement in the medical record is sufficient for you to bill that condition. So it says if there is conflicting medical record documentation, then you need to query the provider. So if somewhere in the medical record it says that the condition is suspected or rule out or versus, then you need to query your provider and get confirmation on whether it is truly confirmed or you only need to code signs and symptoms if the diagnosis has not been confirmed. So let's talk about some general coding guidelines. So let's talk about locating a code in the ICD-10 book. We've been talking up until this point about the order, how to choose the different categories versus subcategories, additional characters. But ultimately, to select a code, you need to make sure that you are looking in the alphabetic index first, and then you are verifying it in the tabular list. Okay? You need to read and be guided by the instructional notations that appear in both the alphabetic index and the tabular list. The reason they both exist is because they are both equally important. You really cannot have one without the other. You need to use your alphabetic index to tell you where to go in the tabular list. Okay, so level of detail. So diagnosis codes are reported based on the highest number of characters available. So if you are looking in your ICD-10 book, specifically say in the Optum published version of your ICD-10 book. I don't know if every version, AAPC or other publishers do it the same way, but if there are additional characters required, it's going to give you either dashes to signify that a fourth, fifth, sixth, or seventh character is required, or it may have a check mark next to it, signifying additional characters are required. Signs and symptoms. If you're following in your book, this is section section IB.18, the use of signs, symptoms, and unspecified codes. Now, if you've been in coding for a while, you may already know. If you're new to coding, you may not know that if your provider documents a definitive diagnosis and the sign or symptom is related or um, uh, inherent to the definitive diagnosis, you're going to lose your signs and symptoms because the definitive diagnosis is going to encompass those signs and symptoms. Now, if your provider has not documented that a definitive diagnosis is confirmed, then you're going to use your sign or symptom instead. Okay. It's very important that we know that if a sign or symptom is included in a definitive diagnosis, that you're not using both. If your provider documents that they are distinctly separate, then you can use both. It all comes down to your provider's documentation and your knowledge of signs and symptoms versus um, definitive diagnosis codes. So let's talk a little bit deeper on signs and symptoms. Okay, we talked just a minute ago, conditions that are not an integral part of a disease process. So additional signs and symptoms that may not be routinely associated with a specific disease or process should be coded when present. So if it is not inherently part of a specific condition. Say, for instance, you have an ear infection and a headache. A headache is not inherently considered a sign and symptom of an ear infection. Ear pain would be considered a sign or symptom of an ear infection that we would regularly associate together. So if your provider documents that the headache is unrelated to the ear infection, you can still code the sign and symptom for a headache. Now, if your provider tells you in the documentation the headache was related to the ear infection, then you're going to lose the headache diagnosis code and only ultimately code for the ear infection. Hopefully that makes sense. So, in addition, you do have multiple coding for single conditions. So, the etiology or manifestation convention that requires two codes to fully describe a single condition that affects multiple body systems. There are single conditions that also require more than one code, and you will see the use additional code notes in the tabular list. And it will tell you that they are not part of the etiology or the manifestation pair, where a secondary code is useful to fully describe that condition. So the sequencing rule is the same. Use additional indicates that a secondary code should be added. And here's the most important takeaway. If known. So if you are coding a diagnosis code and say for instance for instance it says code also tobacco use or tobacco dependence. Well, if your doctor does not tell you that they are tobacco dependent or whatever, then you cannot make that assumption and add the tobacco dependence unless your doctor documents it. So now let's get a little bit further into acute and chronic conditions. We were talking earlier about how there are some diagnosis codes that encompass both the acute and the chronic condition. And then there are conditions like, say, for instance, acute kidney failure or acute kidney disease and chronic kidney disease. Okay, in those cases, those are coded separately. You would code your acute kidney failure, and then you would code your chronic kidney disease secondary. That is a ICD-10 documentation guideline we must follow. It is all about sequencing, and the guideline tells us to sequence the acute code before the chronic code. But there are others like respiratory failure, where there are acute, there are chronic, and there are acute on chronic diagnosis codes. And in that case, if your provider documents it as acute on chronic, you will use the combination code. Otherwise, you will separately uh, use the acute or chronic codes as appropriate. So, combination codes. Okay, this is a single code that is used to classify two diagnosis codes or a diagnosis code with an associated secondary process. This is considered a manifestation. Okay, so it can also be a diagnosis with an associated complication. So, say for instance, diabetes and chronic kidney disease. there is a combination code for type 2 diabetes or type 1 diabetes with an associated chronic kidney disease. So in that case, you're going to sequence your diabetes with chronic kidney disease. So if it's type 2, it would be E11.22. Then you are going to also use the appropriate chronic kidney disease. So if they tell you that it's stage 3A, you're going to use N18.31, or if it's 3B, it would be 0.32. And then there are other choices if it's stage 1, 2, 4, 5, or end stage. End stage would be your N18.6. A little bit further about our sequela or late effects. We did mention this at the beginning of today's presentation, talking about if your provider documents this as a sequela, you need to make sure that if the diagnosis code has the applicable seventh character for A, D, or S, that you are using the appropriate S character for the sequela or late effect. And as I've mentioned previously, if you're following in your book, there are different sections for this for where it is applicable. So, section IC.9 for sequela of cerebrovascular disease, section IC.15 for sequela of complication of pregnancy, childbirth, and the puerperium. And then there's IC.19 for the application of the seventh character for chapter 19. So let's talk a little bit further about impending or threatened conditions. So basically, the thing that you need to remember that impending or threatened may mean that it's potentially going to lead to that condition, okay? Or it's possible that it could progress to this condition. So keep that in mind. Okay, ask yourself if it did occur, you code it as a confirmed diagnosis. If it did not occur, then you need to reference the alphabetic index to determine if the condition has a sub-entry term for impending or threatened, and you can reference your main term entries for the impending or threatened condition. If the subterms are listed, then assign the given code. If the subterms are not listed, you're going to code the existing underlying condition and not the condition described as impending or threatened. So that means you only are going to code the confirmed. If your doctor tells you it's impending or threatened, and there is not an appropriate diagnosis for the impending or threatened condition, you only code the confirmed condition the doctor documents. So, reporting the same diagnosis more than once. So, remember that each ICD-10 diagnosis code can only be reported once for an encounter. This applies to bilateral conditions when there is no distinct code identifying laterality or two different conditions classified to the same diagnosis code. So there are certain conditions that will end in a digit 1 for the right side of the body, a digit 2 for the left side of the body, or digit 3 for a bilateral. You need to make sure that not only is your doctor documenting to the highest specificity, but you're choosing the correct character for the appropriate side of the body. Laterality. So there are some diagnosis codes that specifically indicate the laterality. Mentioned just a second ago, left, right, or bilateral. If there is no bilateral code provided, then you can use the separate sides for right and left. So if there's a specific, say for instance, pain in the body, and there's only pain in right arm and pain in left arm, and there's not pain in bilateral arms, then you will code the appropriate right and left diagnosis code separately. So we have coding exceptions. So code assignment is based on the documentation by your patient's provider. So this can be the physician or a qualified healthcare practitioner, such as an MP or a PA, legally accountable for establishing the patient's diagnosis code. So there are a few exceptions when coding within the medical record documentation from a clinician stating that um, they are the ones that are ultimately responsible for the diagnosis code. So, in this context, clinicians other than the patient's provider refer to a healthcare professional permitted based on regulatory or accreditation requirements or internal hospital policies to document in the patient's official medical record. So you need to make sure that you're not pulling from a RN or an LPN statement in the medical record if it's related to the diagnosis of a patient, because only the clinician, the the doctor, the DO, the NP, the PA, or there are a few other clinicians that I didn't mention that are the only ones that can ultimately assess and treat the patient. You're not going to see an RN, LPN, or other clinical or non-clinical staff that you are able to use what they document to use for when you are assigning a diagnosis code. So to further go into the exceptions, so the exceptions, we're not talking about final diagnosis. We're talking about just documentation within the patient record. If you want to see section IC.21.C.17 for additional information regarding social determinants of health, there is additional information there. But the exceptions to the rule are that other clinical staff can document the body mass index. But remember, that non-pressure chronic ulcers, pressure ulcer stage, coma scale, the NIH stroke scale or the NIH-SS, social determinants of health classified in Chapter 21, laterality, blood alcohol level, and uh, under immunization status are the exceptions. Okay. Syndromes. So if you follow the alphabetic index guidance when you are coding syndromes, in the absence of the alphabetic index guidance, you assign codes for the documented manifestation of that syndrome. So additional codes for manifestations that are not integral to the disease process may also be assigned when the condition does not have a unique code. Remember, we talked about that earlier, is if both the primary condition and the manifestation has an additional code and it is not a combined code with that manifestation, you can code both the primary code and the manifestation of the primary code. So, complications of care. So, code assignment is based on the provider's documentation of the relationship between the condition and the care or procedure, unless otherwise instructed by the classification. The guideline extends to any complications of care, regardless of the chapter the code is located in. It is important to note that not all conditions that occur during or following medical care or surgery are classified as complications. There must be a cause and effect relationship between the care provided and the condition, and the documentation must support the condition is clinically significant. So, as coders, there are conditions we are not allowed to assume are complications of a previous diagnosis. So if your patient that you're coding has a MI, a myocardial infarction, and the doctor documents additional diagnoses that could be considered complications, and they do not directly document a cause and effect relationship, we, as the coder, cannot make that assumption. Okay. If a patient has a CVA, a cardiovascular accident, or a stroke, um, there are what we call residual effects. Your doctor needs to tell you that this is a residual effect of that stroke or CVA. We as coders are not allowed to make that assumption. Borderline diagnoses. Okay. Remember that if you are coding for professional fee or pro fee coding, meaning you are billing for other than facility, these are non facility um, guidelines. It states that if a provider tells you that it is a borderline, you should not code it as confirmed unless it specifically tells you. Okay. If a borderline condition has a specific index entry in the ICD-10-CM, it can be coded as such. Since borderline conditions are not uncertain diagnoses, no distinction is made between the care setting. This means inpatient versus outpatient. Whenever the documentation is unclear regarding a borderline condition, we are always encouraged to query our provider for clarification. We do not need to make an assumption. As we mentioned earlier on signs and symptoms and unspecified codes, remember that signs and symptoms and unspecified codes do have acceptable, even necessary uses. So, when specific diagnosis codes should be reported when they are supported by the available medical record documentation and clinical knowledge of the patient's health condition, there are instances when signs and symptoms or unspecified codes are the best choice for accurately reflecting the healthcare encounter. Remember, we do not bill to get paid. We bill based on the provider's documentation. So if the provider documents chest pain and they don't say other chest pain, it is appropriate to use the unspecified code. I know that we are told, if we get a denial and the unspecified code is not payable, sometimes we might be led in the direction to use the more specified code. But remember, that could be considered fraud or abuse. If your doctor did not document it was the other or other specified code, we are not allowed to change the code on the premise to get a claim paid. So the use of external cause of morbidity codes. So, external cause codes or morbidity is supplemental to the application of the ICD-10 codes. Okay. These are always considered secondary codes. These are not principal diagnosis codes. Okay. Or if you are coding for facility, it would be considered um, principal. If it's a non-ish inpatient setting, it's considered first listed. It just depends on the place of service and where you're coding. So the appropriate injury code should be sequenced before the external cause code. So if there is a fracture, you're going to code the fracture before the external cause. So, meaning where did it happen, when did it happen, and how did it happen? Those are always going to be secondary codes. What actually happened to the patient, the fracture, the sprain, the laceration, the burn, the adverse effect, the poisoning, all of those things are what we are going to code primary to the reasoning behind the actual issue or injury to the patient. So now let's talk about the use of Z codes. So Z codes or other reasons for healthcare encounters may be assigned as appropriate to further explain the reasons um, for the presenting for healthcare services. This includes transfers between healthcare facilities or to provide additional information relevant to the patient encounter. Now, there are certain Z codes that can be the principal or first listed, but there are also Z codes that should only be secondary. And then there are some that can be coded primary or secondary dependent on the circumstance of the encounter. So here are just a few examples of some of the Z codes that you may encounter. So Z59.0, as you can see, we have a dash there, which means it requires an additional digit or character for homelessness. That is a social determinant of health. Now, you may or may not know that social determinants of health codes are not required. They are nice to have for additional information in the patient's chart to explain, say, if they're homeless, they may not have adequate insurance coverage, they may not have a way to obtain medications or take care of themselves. Um, or say, like if they have a leg ulcer, foot ulcer, or other type of condition that has to be treated and kept clean, they may not have access to those type of facilities. And it's great to have as an additional diagnosis, but uh, are not required in the final determination. There is inadequate housing, which is your Z59.1, extreme poverty, persons awaiting adequate facility elsewhere, meaning they're awaiting placement in another facility. That could be a nursing facility, that could be a rehab facility. There are other, you know, conditions, behavioral health that could apply to. And like I said, unavailability or inaccessibility to healthcare facilities, or helping agencies. And but there are other encounters for, say, supervision of a healthy infant or child, or if the patient comes to the visit that day and they're just having a yearly physical or an annual wellness exam if they're Medicare and they're healthy and there are no abnormalities detected. There are specific Z codes for that. There is immunization status for when the patient is just being seen for, say, a flu shot. And then there are other Z codes that represent a status of the patient. For instance, if they are ventilator dependent or if they come in to have a catheter switch out, like a urinary catheter or a non-tunneled catheter, those type of things. There are specific Z codes that we use as supplementary information to further give an understanding to the payer the full picture of why the patient is being seen for today's encounter. So that will finish up today's presentation. There was only one resource for today's presentation, and that was the ICD-10-CM official guidelines for coding and reporting fiscal year 2025. I also included the link, and this was released October 1st, 2024. If you are interested in further presentations, please make sure you follow the Coding Corner Facebook group as well as the Coding Corner YouTube page for additional instructional and educational materials. And I hope everyone has a wonderful rest of your day.